Hi, my name's Tim Board. I'm a consultant orthopaedic surgeon at Wrightington Hospital in Lancashire, and I'm going to talk about day case total hip replacement. I'd like to send my thanks to Dr. Neeraj Sharma, consultant anaesthetist, and my colleague here in Derbyshire, who's also a hip surgeon working at Wrightington. So if we look at length of stay after total hip replacement, obviously Wrightington is the home of John Charnley, who started hip arthroplasty in the early 1960s, and therefore we, as a hospital, we have records in terms of the length of stay dating back to that time. And you can see here that originally it was almost a month in hospital. That did come down quite considerably, but even in the early 2000s, it was almost 10 days in hospital after surgery. When I started as a consultant in 2007, we introduced enhanced recovery programs, and that eventually led to a length of stay reduction to around 3.5 days. But day case hip replacement is something that I was exposed to when I did a traveling fellowship to the States in 2011. And I saw patients there mobilizing on the same day. And I was very impressed with the teamwork that was required in order to do that. And I was interested in trying to bring that into the NHS, but obviously there are certain risks in terms of introducing a protocol like this. Our hospital is quite conservative in some ways, particularly around hip replacement. And if you do a project like this, there's obviously risk to reputation. There's a lot of scrutiny on hip surgery now with GIRFT, with the National Joint Registry. So my initial thoughts were put aside for a little time until, in fact, some other units started doing day case hip replacement in the UK. And then I suppose I got a bit brave enough in order to do that. And also the data started to become quite compelling. So what I'm highlighting on this excerpt from a paper on day case total joint arthroplasty is really showing that of the comparative studies where total hip replacement was done in a day case or a standard setting, the readmissions and the complication rates are always lower in the day case group than in the inpatient group. And that is almost certainly a certain amount of selection bias, but that's fine because all we really need to know is it safe to do it? So the evidence is suggesting that it is safe. So it certainly can be done, it's safe, and it does appear to actually to be low risk. But the question is, do patients actually want it? What's so important that they would need to do on the day to go home in order to do that? Well, I think that kind of comment is missing the point, really. I'm a bit of a Twitter user, and I put this questionnaire out quite some time ago asking, just generally, when would people want to go home after a hip replacement? And the majority would say same day if possible. And at the end of the presentation, I do have some slides from one of our patients, and I will go through that. And I think it gives you some insight into why people might want to actually get out of hospital as soon as possible. So how did we achieve this? Well, essentially, it's all about teamwork. And what we did was we brought a group of people together. Obviously, everybody who's involved in the care of hip replacement patients. Myself as a surgeon, anaesthetist, enhanced recovery nurse, arthroplasty practitioners, physios, OTs, managers, the pain team, pharmacy, ward nurses. And a group from that went to a conference in London in September a couple of years ago. And then we formed this group and essentially then designed a pathway. So essentially we had buy-in from all of these people who were involved in the process. And the pathway went through an iterative change process, and we're now at, I think we're actually now at version 10. And one of the key things has been engagement of all the people involved in the process. And then over a relatively short space of time from instigation to the first case was only 2 months. So this is what the pathway looks like. So it's pretty straightforward on two sides of A4. And it really takes the patient through right from admission to discharge. And this is put on the front of the note. Certainly at the very beginning, we had this on the front of the note. So anybody who in the hospital was unfamiliar with the day case program could look and see at any point in the patient's pathway where they are and what's going to be happening to them. and the inclusion criteria and the discharge criteria are there. So essentially we have people first on the list. They can drink up to 2 hours before surgery. And I think one of the crucial things for early mobilization is avoidance of diamorphine in the spinal. The operation is exactly the same. I do exactly the same approach. I do posterior approach for all of my hips. We infiltrate with local anesthetic. So, you know, it's not me that is important in this, it's everybody else. As I said, you can see the anesthetic agents that are used there in terms of tranexamic acid, dexamethasone, obviously fluid replacement as well. And then when the patient is in recovery, we give them a carbohydrate drink as soon as possible, start with the analgesia, and then they return to the ward. And this is obviously where the physios come in, and the physios assess the patients within 2 hours of surgery and assess their muscular control and basically mobilize them as soon as possible. And then it's an hour. After every hour, the physios come back and do further physio with the patients and mobilize them through their independence and eventually getting them ready on the stairs. From an analgesia perspective, you know, we've gone pretty straightforward and simple. So it's paracetamol, codeine, Oromorph for breakthrough, and naproxen as an anti-inflammatory as well. So I did this as a quality improvement project, and as many of you probably aware, you know, PDSA loops are used. And just an example of one thing that we had going on here, the first patient was a little bit lightheaded on day 4 when they were contacted, and we kind of looked carefully at our techniques for reducing blood loss. But perhaps the more interesting thing was that I noticed that first patient in the recovery room, the recovery nurse was talking to him, and I could overhear a conversation. Oh, day case tip replacement. I'm not sure that's very sensible. Why are you having that done? And I thought, oh, that's not going to help. You know, negative discussions like that. So I had a chat with that nurse, and you know, talked about her reticence, and actually invited her to join the group. So she did, and then subsequently became quite an advocate to it. So I think, you know, that kind of bringing in people into the group, into the fold, as it were, I think is a really helpful thing to do. So progress. So this was our first patient, Charlotte, who actually was an ex-staff nurse, and she was really delighted with her surgery, and she was a good advocate on Twitter, saying how well it had all gone. And that's her kind of walking within a couple of hours after surgery. Maybe it might not be very obvious to you which side she's actually had replaced. She's doing very well with her mobility. So, you know, I think patient-public involvement is really important in this. The most important factor, I think, to success is patients wanting to be discharged as soon as possible. If the patient doesn't want to go home, they're not going to be going home. What have we achieved? So out of the first 31 patients, we had 26 that went home on the day, and we had 4 that went on day 1 and 1 on day 2. If we look at what were the reasons for that, we had one patient that had kind of slow return of her quads, one with some reduced dorsiflexion that did settle, one patient was catheterized, and one patient chose to stay overnight. So we always say to patients, you know, we do have a bed for you. There's no pressure. If you want to go home, you can. But if you feel that it's all too much, then fine, you can stay overnight. You can see on the left there, the as I mentioned before, standard posterior approach. So no difference in the surgery. And we've used a variety of implants. So mostly uncemented, but some hybrid with cemented stems as well. We do follow up the patients. You know, when they go home, they get a follow-up phone call on day 1 and 3 by the enhanced recovery team. We've had 29 with no complications or any concerns at all, one with a little bit of moderate swelling that settled, and one with a wound ooze, but subsequent 3-day wound check was absolutely satisfactory. So as you might expect with total hip arthroplasty, you know, it's a low rate of complications and a high success rate in terms of return to activities. But what about their analgesia? What are they like at home? They go home from hospital. Do we have any idea how much pain they're in? So the pharmacy did an audit, and they looked at, at day 3, so 23% of patients were taking paracetamol, 77% were taking paracetamol, naproxen, and codeine, and 30% of the total required some top up with Oromorph prior to sleep or prior to exercise. And at day 7, 100% of patients were just taking paracetamol and naproxen. And they reported in terms of the qualitative outcomes that no patient was dissatisfied. I did have a little bit of kickback from some colleagues about the demands on the physio that Daycase does produce. So we did an audit on that. And a Daycase patient requires an average of 81 minutes of physio with 2.7 contacts per admission, whereas a standard, enhanced recovery is what we now call standard, had 138 minutes with 4.6 contacts. So overall, there's less demand on physio per patient, but the physio input is just on the one day. So you've got to get over a hump of having enough patients, and then it becomes a lot easier. From the financial point of view, obviously you're going to save money if you have people going home earlier. And this was from divisional accountants who calculated that we'd estimated we could perhaps do 10% of our total number of total hip replacements. And what would that save? And the answer was that would be about £100,000 a year. So what about thoughts and future direction? Well, as I said, I think patient motivation is absolutely paramount. I think it needs to be supported by the hospital as well. I did this as a quality improvement project and had sort of trust board approval. And therefore there was a feeling that it was a safe, effective and low risk thing to do. Obviously, we've done this as a separate pilot, but other units have gone for wholesale change. And I think you do need to weigh up the risks and benefits of doing that in individual units. And I think how big a unit is, how disparate the consultant body may or may not be, and how engaged everybody is, makes a difference to how you might introduce this. We have seen a crossover in anaesthetic techniques, and therefore we've seen a reduction in length of stay for our other total hip replacements as well. So that's been a real benefit. I think if we had if we've got a mobile home care teams, a team of nurses or physios that could go out to patients at home on the first day post-op, I think we probably would be able to widen the net and have more patients to be suitable. So these are some slides that Charlotte put together. She was our first patient that went through the process. So these are some of her thoughts. So preoperatively, she was very apprehensive. And in fact, I remember her saying that she put off having a hip replacement for years and years because she was so scared about being in hospital despite being a nurse. And she said, I'll only have it if I can go home on the day. She was obviously worried, the general worries about surgery. Would the surgery be a success? How would it be post-op? And she says that having Daycase surgery gave me the courage to make the leap. Being in hospital on the day of surgery, she says lots of things were happening. Knowing that I was going home helped focus on the end goal. She felt empowered at having made that decision. Very relieved, obviously, after surgery, constant care around her. I think, that is a theme. I think when you have a standard hip replacement, you come back to the ward and a lot of people just spend quite a lot of hours just sitting around waiting for things to happen. But the Daycase people, they keep getting people coming back in, doing more and more physio with them. Nice to know that she felt encouraged rather than pressured to mobilize. And then at the day of op back at home, again, this is a recurrent theme, in control of own pain meds. I think that's a real empowerment factor with these patients. They go home with their own medications, they have top-up oral morphine, and they're in control. They're not lying in a hospital bed with a buzzer that they keep pressing and doesn't get answered. And I think that makes people feel a lot more comfortable. Like I said, feel less like a patient at home, in control of her own pain. And then just some comments about, how she's done post-operatively since then. So she's done very well. So thank you very much for listening. I'd encourage you all to try this. I think you do need, the keys are that you need to get a team around you of everybody involved in the care of the patients, get everybody on board, get an agreed pathway, and then go for the patients who are really motivated and keen to do it. And you will succeed. and I'm more than happy to speak to anybody about that. My Twitter is at the bottom here. You can contact me directly on that. Thank you very much.